Good morning, everybody. It is exactly noon in New Orleans. It is 7 p.m. in Paris, 6 p.m. In London. I think 1 p.m. in New York. And it is my great pleasure and big honor to welcome all of you to this take-home messages broadcast by the International Academy for Clinical Hematology. I'm Mohamed Moti from the Sorbonne University and Saint Antoine Hospital in Paris, in France. And I'm very fortunate to be joined today by an incredible, an amazing number of great experts and friends who will just without any slide give you, maybe while you're heading back home to the airport, while maybe you're sitting in the airport lounge, while maybe you are in the car, in the train, or at home preparing dinner in Europe, getting ready to sleep in Asia, or maybe just waking up in California. We're going to give you some key take-home messages from this beautiful and quite amazing IACH 2022 annual meeting held in New Orleans. I can assure you, and this is really very sincere, I tweeted earlier today that after almost 3 years of pandemic, I felt extremely energized myself, boosted by the dynamic, by the optimism, by the enthusiasm I could encounter at this meeting, where some amazing discoveries and new innovations have been discussed and described. And another major highlight of this IACH, as you may have guessed, is that we had some key soccer matches. And we had, of course, the plenary session dedicated to the game between France and England. And of course, you know the results. And here I'd like to say a big hello to all my English friends across the globe. The game was fantastic. Also, I know that some of you are getting ready for another game in an hour. So hopefully we can keep your attention for the next 60 minutes or so. So I'll start immediately because I know some of our panelists and all of them are in New Orleans, guys. This is being live. I don't know, maybe you don't care, it's digital, but it's nice, you know, to say we are there and we're bringing the information for you live. So let's start, and I will start by, I think, the same order, by the way, you know, people are going to travel because they have their planes. So my first panelist is going to be you, Professor Zidane from Yale University, and we'd like to hear a lot about MDS, your key highlights, and we'll follow by the lymphoma CLL stories, and then followed by allotransplant and multiple myeloma. But of course, all the panelists can just jump in and comment if they wish, because it's always enjoyable to have the opinion of someone who is, I don't know, following CLL, but listening to what's ongoing in MDS. So Amer, please, the floor is yours. What are your key take-home messages from this IACH 2022?
Yeah, thank you so much, Mohammed, for the kind invitation and this opportunity to connect with everybody. The MDS session actually for me was something I was looking forward to. I was actually the coordinating reviewer for the meeting for the MDS this time around. So I had like a preview of the abstract since last August, and I certainly was looking forward to all the excellent presentations that we have seen. And I think you could probably divide the abstracts into potentially three major areas this year. I think we continue to have some lag from the COVID era in which we had a lot of delays in clinical trial activations. So we did not have a very large number of new drugs presented or big trials presented. I think the main focus, and that took a significant number of the abstracts that were presented in the oral sessions, focus on the new classifications. As I'm sure your viewers are aware, this year there has been updates both to the WHO, which was updated in 2020 on myeloid neoplasm and lymphoid ones, but focusing here on the myeloid side, as well as a new classification, the ICC. And there was a lot of discussion about this over the last few months, and we started to see some data-driven approaches to compare these two classifications, because the field is actually, in all honesty, a bit concerned about the ramifications of having two divergent classifications and how would that impact not only clinical trial eligibility and regulatory process for drug approvals, but also patients' understanding of their disease and the confusion that it can create when they hear they have MDS or AML or something different when they go to two different doctors. The second area focused on the IPSSM, which is a molecular IPSS. This was also another major publication this year, earlier in the New England Journal of Medicine of Evidence. What happened is that multiple groups have published their own validation experience of the IPSSM and how does that basically reflect in real life data. But also there's a number of abstracts looking at the molecular alterations with a focus on TP53. We could actually have a whole session on TP53 given the large number of abstracts that have been submitted to the meeting. And then the third area is focused on the clinical trial development. So just as major themes, starting with the first area, I think one of the, best abstracts that was presented, I actually love the title of it. It's called The Clash of the Titans, basically looking at the comparison of the ICC versus the WHO classification. And I think the main message from that is that some aspects from both scores seem to, or from both classifications, seem to function better than the others, using a Moffitt database of a very large number of patients. So I think what will need to happen is to merge both classifications ultimately in a way that would be more patient-centric. And I think we are going to see more of this work from other groups over the next few months. The second area, I think the molecular IPSS was certainly validated. Multiple groups have published, and we already saw actually a couple of publications already, in addition to the presentations that we have seen, that the molecular IPSS does indeed improve upon the revised IPSS, which was a traditional risk tool that we use in MDS. And the molecular IPSS was one of the largest attempts to integrate molecular testing. So I think this is going to become of more importance, again, not only in terms of clinical trial eligibility and how you approach risk stratification MDS, but also in clinical practice. The main concern and the main debate continues regarding how easy it is to access next-gen sequencing, especially globally. One of the main things I always try to promote, I know this is also close to your heart, is that the developments that we see are not only restricted to the US and Europe, and how to apply that basically beyond to the rest of the world. And certainly not every place you can get next-gen sequencing, and you cannot get it reimbursed. So I think the solution is going to be to use these scores, but also continue to use the scores that do not necessarily have the molecular data in them. But I think it's clear that the molecular IPSS has significant advantages over the revised IPSS, and molecular data should be always used when possible. In terms of the clinical trials that were presented, there was only one randomized clinical trial. The others were basically phase 1 or phase 2, or updates from previously presented trials. For the randomized phase 2, I actually presented on behalf of our co-authors the results of the Stimulus MDS1 trial, which is a randomized study of sabatolimab. This is an immune checkpoint inhibitor against TIM3. So there has been preclinical data suggesting that TIM3 is important in the pathogenesis of myeloid malignancies. It's not only as an immune checkpoint pathway, but also directly expressed on the leukemia stem cells. and there could be a direct targeting there. Early phase clinical trials presented several times basically have suggested activity in a phase 1 trial by increasing response rates and potentially a signal of progression-free survival improvement. So this randomized study was undertaken. We randomized 127 patients. It was a double-blind placebo-controlled trial of azacitidine with placebo versus azacitidine with sabatolimab. The trial was global, 17 countries, I believe 47 centers, and patients were randomized in one-to-one fashion, around 65 patients in each arm. And the primary endpoint was a combined endpoint of CR and progression-free survival. The primary endpoint was not met on this trial. However, what was seen is some delayed separation, which could reflect immune therapy mechanism of action that you can see that in the solid tumor experience, suggesting that maybe with longer follow-up, you could see some impact. And this is going to be explored in the phase 3 trial. So there's a similar design phase 3 trial, but much larger, 530 patients. This trial has already completed accrual and is going to be looking for that delayed effect in terms of evaluating for overall survival, which I think is clearly the most important endpoint rather than CR or progression-free survival. Aside from this trial,
Amer, just to clarify to our audience, because I'm not sure everybody is familiar with this really fantastic sabatolimab work, that it is expressed on leukemic stem and progenitor cells, making it a potential target actually in AML, MDS, and it binds to TIM3 on the surface of T cells, releasing the brakes that the tumor applied to the immune system. Just to clarify this, because I'm not sure that everybody is familiar. Everybody heard about PD-1, PD-L1, I would say checkpoint inhibitors, but this is something new targeting TIM3. And this is quite unique because I think it will go beyond MDS in myeloid malignancies. Am I correct?
You're absolutely correct. And it's actually quite interesting because TIM3 and also CD47, which I suspect many of your audience heard about, these two immune checkpoint pathways are being explored extensively in myeloid malignancies rather than the traditional CTLA4, PD-1, PD-L1, TIGIT. And CD47, we did not hear in this ASH updates from what was previously presented, but there's also randomized phase 3 trials with this drug called magrolimab, which works on the CD47 don't eat me signal. The third large trial that is enrolling is venetoclax with azacitidine. This trial called the Verona is also still enrolling, and we hope to hear news on both of those trials next year. In terms of other efforts that have been focusing on lower risk MDS, we have luspatercept, which is basically a ligand trap that works on the transforming growth factor pathway. This drug is already approved in the US and I believe in Europe actually, based on
absolutely.
Based on the COMMANDS trial that showed improvement in transfusion independence rates in patients with lower risk MDS who have anemia. The big news actually was not presented for this drug in ASH, but it was a press release for the frontline study called the COMMANDS. This was press release just before ASH that the trial met its primary endpoint as a frontline treatment, and not only in patients with, in patients who have ring sideroblast or not, basically. This was the release. So we are hoping to see this data next year in some meeting because it could be also practice changing. There are also updates on the imetelstat, which is another first-in-class telomerase inhibitor. Very nice transfusion independence data, some long-term responders. We have heard this update from Dr. Ove Latzbecker, as well updates on the use of oral decitabine, both in lower risk and high risk MDS, and especially in patients who have TP53 mutations. Those patients continue to be the most difficult patient population to treat, and a lot of the new drugs are focusing on this area. Just a couple of points, I guess, on the leukemia, acute leukemia front. Just before we had our talk today, the late breaking abstracts, basically, I think is probably the most important of this meeting because it's probably immediately practice changing, which is the integration of blinatumomab, which is a bispecific T-cell engager This has been approved in the past for refractory relapsed B-cell acute lymphoblastic leukemia. However, upon integration in the frontline setting as part of the consolidation treatment, a very nice overall survival advantage in the E19110 cooperative group trial. So I think this will certainly lead to integration of blinatumomab as part of the frontline treatment for patients with B-cell acute lymphoblastic leukemia. I think this is something that's going to happen very soon. And I think the other major change in practice, probably, I suspect Dr. Dabaja is going to cover it in terms of prophylaxis for GVHD on acute leukemia patients.
Excellent. Thank you very much, Amer. So clearly, in MDS, the field is going into this molecular, I would say, characterization of MDS, which actually will guide the targeted therapies, but also maybe the indications for allotransplant and the different now novel treatments. The AZA venetoclax story is still ongoing, so hopefully next year. But I think it is really great news to see that a new family of checkpoint inhibitors, namely this sabatolimab new drug, is making its way. And actually, last but not least, you mentioned the late-breaking abstract we had 1 hour ago about the role of blinatumomab maintenance, which is beneficial actually for almost everybody, all of these patients. We'll talk a little bit about the transplant actually for ALL, where, because actually now, thanks to these wonderful, I would say, bispecifics and TK inhibitors in some cases, these patients are, many of them are being cured. Thank you very much, Amer. Let's move to you, Professor Harfan Dabaja from Mayo Clinic, Jacksonville. And you have followed closely the CLL field, I think. And here's a CLL field. Well, obviously, we knew that CLL outcome has been dramatically revolutionized since the introduction of BTK inhibitors. But now there are even more data, and we had also some plenary talks about it. What is your take on the CLL messages?
So thank you, Dr. Moti, for allowing me to be here with you today. I think that if I were to summarize the advances in CLL, I would certainly divide them into two major groups: treatment of the relapsed refractory CLL and treatment of CLL in the frontline setting. So as we have heard less than an hour ago, one of the late-breaking abstracts presented by Dr. Jennifer Brown, we look at the results of zanubrutinib, which is a new generation of BTK inhibitor, and it's compared to ibrutinib for treatment of patients with relapsed refractory chronic lymphocytic leukemia / small lymphocytic lymphoma. This was the result
and just to clarify, Mohammed, to our audience, that the paper is already online from the New England Journal of Medicine.
That's correct.
It has just been released simultaneously to the talk.
Yeah, this was released less than a couple of hours ago, correctly. So this was a randomized phase 3 study known as the Alpine study, and it compared head-to-head ibrutinib versus zanubrutinib. Patient must have received one or more prior lines of therapy and should have measurable disease. Randomization was 1-to-1 to either zanubrutinib or ibrutinib, and the randomization was treatment was until disease progression or if the patient developed unacceptable toxicities. Over 650 patients were enrolled, 15 countries, and 327 or so went into the zanubrutinib arm, and around 325 went into the ibrutinib arm. Median follow-up of almost 30 months, PFS being assessed by an independent review committee, showing superiority over ibrutinib with a hazard ratio of 0.65. So when you look at the numbers, median PFS for ibrutinib was 35 months, and for zanubrutinib was not reached in the treated patients. Moreover, not only it shows more efficacy, but the toxicity profile of zanubrutinib was more favorable. Treatment discontinuation rate was lower with zanubrutinib, around 26% versus 41% for the ibrutinib-treated patients. Now, one of the unique aspects of BTK inhibitor is the cardiac toxicity. And when we look specifically at discontinuation due to cardiac disorders, it was 0.3% for zanubrutinib versus 4.3% for ibrutinib. So obviously, this study shows that zanubrutinib has a proven superiority to ibrutinib, not only in terms of overall response rate, but also a progression-free survival in a patient with relapsed refractory CLL, with a more favorable toxicity profile, in my opinion, and based on the data that was presented. I think that the other important study, not randomized, and certainly this was an update of a previous study known as the Bruin study, which is a phase 1/2 study. It looks at a different compound, and here we need to start focusing on these terminologies: covalent inhibition and non-covalent inhibition. So ibrutinib and zanubrutinib are both covalent inhibitors of BTKI. So this new compound called pirtobrutinib is actually a non-covalent, meaning it's reversible. It does target both the wild type as well as the C481 mutant BTKs. So this study presented by Dr. Mato and colleagues, patients who had previously treated B-cell malignancies, including among them CLL and SLL. So here they reported over 270 patients with CLL who had failed prior BTK inhibitors. Median age close to 70 years, I believe was 69 years of age, and the median number of prior therapies was around 3. This patient had also have additional prior therapies. Almost all of the patients have received anti-CD20 antibody therapy, and I believe BCL2 inhibition was offered to around 44% of those patients. So by all criteria, these patients were heavily pretreated, and I believe some cases have also failed CAR-T therapy within the context of the clinical study. This patient had
just one clarification, Mohammed. I think there was a subgroup about Richter transformation.
That's correct. That's correct. Yeah, correct. And I'm going to be presenting that after. So for the group that is the all-comers here, CLL, the important thing, the take-home messages, I think, is that around 84% of these patients did receive the recommended dose, which is 200 milligrams once a day as a starting dose. The overall response rate, keep in mind, these are BTK inhibitor failures with previously covalent inhibitors. Overall response rate was around 74%. Most of them were either partial responses or partial responses with lymphocytosis, accounting to around 72% of all of those responses. Median follow-up of almost 14 months, and the median PFS is around 19.4 months. So certainly impressive data when you consider that these patients have been BTK refractory or resistant, and almost half of them have failed BCL2 inhibitors. So I would say this is one of the most promising products in the horizon for CLL therapy. This product is not yet approved for this particular indication. As you mentioned, Dr. Moti, there is also a subgroup study which was presented also. It's around 57 patients, and these patients have Richter transformation, median age of around 67, and around 91% of these patients have received at least one prior chemoimmunotherapy directed and anti-Richter therapy. The median number of prior therapies was around 2, and these patients have also had a median of around 2 prior CLL-directed therapies. So very heavily pretreated. Dose use was similar to 100 milligrams daily, and 98% of these patients were able to tolerate that particular dose. In this particular group, response was evaluable in 50 patients, and the overall response rate was 54%. So 5 of those were complete responses, and 22 of the 50 evaluable patients had a partial response. So overall response rate, 27 out of 50 patients. Median follow-up still short, around 5.5 months, but the duration of response has been around 8.5 or 8.6 months, I believe. So this is important. I think that this is a new concept that will continue to evolve of these non-covalent inhibitors, particularly for those patients who develop resistance to the BTKI. The third study, yeah, go ahead.
So I know I was going to play with words because I'm almost sure you're going to speak about the Clarity study, which was another highlight. So maybe just to have a strong and clear message for those colleagues treating CLL. Today, if you have to treat CLL with a BTK inhibitor, where would you go?
Well, certainly that's a complex question, right? It depends of we're talking about the relapsed refractory setting or the frontline setting. I think more and more data is emerging in the frontline setting, which I'm going to discuss in the second half of this summary. But I think that the concept of time-limited therapy using chemotherapy-free regimens is really where the field seems to be moving. And there is exciting data on a couple of studies, the Captivate, and I would say single situation study from MD Anderson by Dr. Jane and colleagues, who reports, I think, 4 years of follow-up. But if you allow me to finish on the Clarity study, Clarity was in the context of patients who had relapsed refractory CLL also. Around 50 patients were treated. And here the intent is to use ibrutinib plus venetoclax to try to determine if we can ascertain the persistence of an MRD negative status with a prolonged follow-up. So 54 patients were recruited for that study. It took them from May 2016 till November of 2017, heavily pretreated cases. In some of them have received up to 6 prior lines of therapy, but the median was around 1. Around 20% of them had bad risk mutations like 17p, and 3/4 of those patients have unmutated IGHV. 50 patients were evaluable. 14 of those patients achieved MRD negativity with an level of detection that was used was 10 to the -5, basically following the ERIC standard flow cytometry recommendations. So of those 14 patients, 13 patients have not progressed. Today, there was only one progression of one of the patients that was MRD negative and did progress. So I think we're more and more starting to really show that those MRD responses are durable, and that and this will certainly continue to be the theme, in my opinion, for treatment of relapsed refractory CLL. Now, if you allow me to jump into the newly diagnosed CLL, I think that probably the study that I personally have been waiting to see is the Captivate study. This is a multi-center phase 2 study. Looking in this, actually, there's some noise there. So this study was looking into a patient who were treated with ibrutinib and venetoclax, and then they look at this particular cohort that achieved MRD negativity. This was confirmed MRD negativity using established criteria for the definition of MRD negativity. Looking at the concept here is those patients who were MRD negative were then randomized to either receive ibrutinib or to basically receive a placebo. And when we look at these patients, at 3 years, disease-free survival was similar. Whether patients were receiving the placebo was 85% versus 93% for those who were receiving the ibrutinib, with a p-value that was not significant. 4 years of progression-free survival was 88 versus 95, and the survival was 100% versus 98% at 4 years. So I think we started to see that those patients probably who achieve MRD negativity, you could say that the placebo performing as good as the maintenance ibrutinib, this is certainly something that I would say would be possibly a game changer for the treatment of newly diagnosed CLL. I think very similar data, I would say, coming from the group at MD Anderson. They also report 4 years of follow-up, showing a very similar theme that these MRD negative patients, after receiving ibrutinib plus venetoclax combination and have confirmation of MRD negativity. Those patients indeed have durable remissions, and those MRD negativities can be sustained over a long time. I think there are other studies that certainly are continuing to evolve. There are new phase 1 trials showing newer molecules. But I would say that, in my opinion, these are probably the most relevant to the clinical practice that we are working nowadays with.
Thank you very much, Mohammed. And I'd like to reassure our colleagues that here we are taking the hot take-home messages, the immediate reaction. But of course, the IACH will organize more detailed with supportive slides, post-ASH webinars on specific topics like lymphoma, myeloma, transplant, CLL, etc. But here, what I can hear from you, Mohammed, is that the key words today, if you just summarize it by words, is alpine trial or alpine, whether how you pronounce it, just published in the New England Journal of Medicine, late breaking abstract. It is the Brune trial. It is having more clarity on clarity and being captivated by Captivate in CLL. Thank you very much and wish you a safe travels. So, and Ali, this is very interesting because we spoke a lot about BTK inhibitors in CLL, and when it comes to lymphoma, one of the key presidential abstracts was about the use of BTK inhibitors, namely ibrutinib, in mantle cell. And it looks like auto-transplant in mantle cell is going to die soon. Any thoughts? And would love to hear from you about your key take-home messages in the field of lymphoma from ASH 2022. Thank you all for joining, by the way, and people continue to join. We're very grateful to your loyalty. It's now a little bit more than noon in New Orleans. Ali, the floor is yours.
Thank you very much, Mohammed. So good morning, good afternoon, good evening all over the world. My name is Ali Bazarbashi. I work at the American University of Beirut in Lebanon, and I joined Dr. Moti in his feeling about the energy from coming back to physical meeting at ASH rather than the previous virtual meeting. So lymphoma is one of the most curable malignancy, and still we have seen so many progress this year at exciting data at ASH, including one of the 6 plenary abstract talk and one of the 6 late breaking abstract also on lymphoma, and many other exciting data and oral sessions. So you just mentioned, Mohammed, about mantle cell lymphoma, and actually this is, since we love names, this is the randomized triangle trial by the European Mantle Cell Lymphoma Network, and that was presented by Martin Drelling in the plenary scientific session regarding efficacy and safety of ibrutinib combined with standard first-line treatment or as substitute for autologous stem cell transplant younger patients with mantle cell lymphoma. So as you know, that till now, the standard of care for young patient with mantle cell lymphoma is high-dose cytarabine chemoimmunotherapy. So this was based mostly on the work from Olivier Hermine and the European Mantle Cell Lymphoma Network. followed by autologous stem cell transplant, and then more recently, maintenance rituximab post-transplant every 2 months for 3 years. And there have been a lot of data about the efficacy of BTK inhibitors, particularly ibrutinib, whether in relapsed mantle cell lymphoma or as first-line treatment for mantle cell. And in 2016, the European Mantle Cell Lymphoma Network initiated this open-label 3-arm triangle trial to evaluate. Actually, there are multiple comparisons. This is why it's called triangle. So you have 3 arms. One is the standard arm, chemoimmunotherapy, autotransplant, and maintenance rituximab according to the center practice. The second arm is chemoimmunotherapy plus ibrutinib, autotransplant, and then maintenance ibrutinib plus or minus rituximab according to center practice. And the third arm is without autotransplant, is chemoimmunotherapy with ibrutinib and then maintenance ibrutinib. And actually, this is a quite large trial. They included almost 900 patients, 300 in each arm. And and they presented this data after a median follow-up of 31 months. So there are multiple messages from this trial. The first is that there is a clear superiority of adding ibrutinib in terms of response rate and PF compared to autotransplant alone without the arm of autotransplant alone without ibrutinib. To give you an idea, the 3-year failure-free survival and the was 86% for the ibrutinib arm versus 72% for the autotransplant arm. So if you just you can eliminate autotransplant and do ibrutinib. If you have to choose, ibrutinib appears superior. Now, the more tricky question to which this trial did not yet answer because the number of events is too early is whether we can combine the two. If there is an advantage of adding ibrutinib to autotransplant versus ibrutinib alone or autotransplant alone. And for that, I mean, A plus I was superior to A, 88% versus 72%, but the 3-year overall survival was 86% in autotransplant alone, 91% in autotransplant plus ibrutinib, 92% in ibrutinib alone. So we cannot tell yet. We can say today as a take-home message that if you have to choose autotransplant or ibrutinib is superior. If you want to choose autotransplant plus ibrutinib versus ibrutinib alone, whether now ibrutinib becoming the new standard, the question that requires more follow-up is whether we still have to do autotransplant or not. We need more follow-up to answer this question. So
this is really incredible, Ali, because mantle cell lymphoma used to be considered as a terrible disease, and you're telling me now we're talking about an 88% disease-free survival. This is, I mean, really energizing.
So something even more futuristic and energizing is in diffuse large B-cell lymphoma. It is a phase 1b study, so we're moving from randomized phase 3 to phase 1b, but about glofitamab plus R-CHOP induces high response rates and a favorable safety profile in patients with previously untreated diffuse large B-cell lymphoma. This was presented by Max Top. Actually, you know that glofitamab is CD20, CD3 T-cell engaging bispecific monoclonal antibodies, and that has shown efficacy in the relapse refractory setting in diffuse large B-cell lymphoma. And now it is being incorporated in the first-line treatment. So patients in the trial receive one cycle of R-CHOP as debulking to mitigate the cytokine release syndrome risk. And then they received a total of 6 to 8 cycles of R-CHOP 21 with intravenous glofitamab starting cycle 2. And at the data cutoff of May 2022, 56 patients were enrolled for the safety population. And of these, 46 patients reached their scheduled end of treatment assessment. Median age was 68 up to 84, and 96% of the patient has stage 3-4 disease, and median IPI score was 3. And the complete metabolic response rate was 76%, and the overall response rate 93.5%. Grade 3 adverse event related to glofitamab were only 23%, and serious adverse event related to glofitamab 8.9%, 5 patients only. And there were no severe grade 3 to 5 CRS events and grade 1 to 2 cytokine release syndrome event in 10% of the patient only, and no glofitamab related neurotoxicity, neurologic adverse event potentially consistent with immune effector cell associated neurotoxicity syndrome were reported. So, and this is actually something for the, it's not a practice changing for tomorrow, but this low incidence and severity of CRS, this minimal toxicity, and this very promising efficacy in this phase 1 suggests that glofitamab can be safely combined with ARCH as a fixed treatment for patient with first-line DLBCL, particularly that the dose intensity of R-CHOP was maintained in all patients. And this is glofitamab R-CHOP may be suitable for the outpatient setting. So with this bispecific going to replace CAR T-cell in diffuse large B-cell lymphoma and becoming, I mean, moving to the first line. This is, if the results are confirmed in a randomized trial, this can be the future moved seminal trial of Tranquafier from CHOP to R-CHOP. So whether we're now moving from R-CHOP to Glofi R-CHOP, we need to come next year to ASH. Mohammed, you are muted.
Fantastic, I was saying, and I would like to mention, as I did for the Alpine trial, that if you would like to hear and know more about glofitamab, there is also the publication in the New England Journal of Medicine, which came out actually on December 11 about glofitamab for relapse refractory diffuse large B-cell lymphoma with some quite impressive results in a series of 155 patients. So we will have, I think, as part of the IACH post-ASH activities, a specific webinar in January dedicated to bispecific and tri-specific antibodies in non-Hodgkin lymphoma. And this is going to be, I think, by last week of January. And will be Dr. Clémentine Sarkozy, who will give us a summary from the IACH data. Any other lymphoma highlights?
Yes, Mohammed, 1 minute to mention the update from the TRANSFORM trial. This is the primary analysis of the randomized phase 3 TRANSFORM study. So liso-cel versus standard of care with salvage chemotherapy followed by autotransplant as second-line treatment in patients with refractory or early relapse diffuse large B-cell lymphoma. So confirming the previous superiority and by far large superiority of CAR T-cell over the standard of care in this high-risk refractory or early relapse diffuse large B-cell lymphoma. Another highlight of 1 minute is for primary mediastinal lymphoma. So this is a disease where the standard of care is more tricky, and people are using either R-CHOP 21, R-CHOP 14, the dose dense, R-CHOP, RACVBP, the dose intense, or dose adjusted epoch, depending on where you are working. And actually, the GILA trial compiled the data, the LISA group compiled the data from multiple 5 prospective clinical trials between 2003 and 2015, with a very large number of patients with primary mediastinal lymphoma and with a central pathology review. So they collected 290 patients. And overall, I mean, the take-home message is that the 4-year PFS was 64% for R-CHOP 21, 78% for R-CHOP 14, 86% for RACVBP, and overall survival was inferior in R-CHOP 21, 73 versus 88 and 89%. So clearly R-CHOP 21 is inferior to more dose dense, dose intense. So you can go for R-CHOP 14 or RACVBP, which had the highest PFS. But I think that R-CHOP 21 is suboptimal for primary mediastinal diffuse large B-cell lymphoma. And the final message is the MATRIX trial. This is in primary CNS lymphoma, consolidation therapy in patients with primary CNS lymphoma, the international randomized phase 3 MATRIX trial that was just presented 1 hour ago in the late breaking abstract session by Gerald Illerhaus. And actually, as you know, patients with primary CNS lymphoma, their standard of care when they are eligible for autotransplant was autotransplant. And in this trial, autotransplant was challenged with chemotherapy. After induction with rituximab, high-dose methotrexate, and high-dose cytarabine and thiotepa-based induction, responding patients were randomized to autotransplant with conditioning based on BCNU thiotepa or busulfan thiotepa versus chemoimmunotherapy rise, like I would say, and for once autotransplant was largely superior. So they challenged autotransplant, but autotransplant was the winner in this trial, and consolidation with autotransplant resulted in significantly better outcome with 3-year PFS of 79% versus 53% after chemoimmunotherapy consolidation. So that was in the late breaking abstract session.
Thank you very much, Ali, really for this really amazing summary. So again, in lymphoma, the keywords about triangle. So watch out for the triangle story, guys, in mantle cell lymphoma, but also bispecific antibodies everywhere. And that's going to be the keyword in myeloma. But before moving to myeloma in around 10 minutes or so, I'd like to ask Professor Blaise to give us his highlights when it comes to allotransplant, because guys, despite the revolution of immune therapy, actually the first generation of immune therapy, namely allogenic stem cell transplantation, continues to be developed because this is the only current curative therapy for many myeloid malignancies. And actually, we had a randomized trial in allotransplant in the presidential session. We had another randomized trial about GVHD prophylaxis as part of the late-breaking abstract a couple of hours ago. I know you're getting ready for the match between Croatia and Argentina, but don't worry. I will keep you updated about the results during our broadcast because I have my other screen next to me following. So Didier, your take-home messages from ASH before taking your plane later today.
Thank you, Mohammed, for inviting me today, and it's a pleasure to be with you. I will just first comment on your comment on the energy that you felt in the corridor of this meeting. And in fact, it's really true. And it's not only, we may ask the reason why, of course. It's after several years of no meeting, non-site meeting, it has been some kind of release to be able to discuss in the corridors with other investigators. But it's not only that. It's the fact that we have a very peculiar time because we have successful. All the work that have been done over years is really important and give good achievement. You already mentioned the result concerning mantle cell lymphoma, for example. Ibrutinib is used for many years, and we can change really a situation that has been very bad so far in a very good situation. And according to that, I do think that one of the feeling I have is the fact that we have a real maturity, at least in transplantation, on the question asked by different investigators. It's always technical aspect. It's important to improve the tool that we are using, but it's more and more how to use this tool in order to give to the patient a good survival and a good survival. So there have been many aspects, and I will not address this kind of question today, but it's important concerning quality of life and how to monitor that, how to take to care about the patient and not only to cure this patient. And the second point is that there have been in transplantation at least 2 areas that have been really developed during this meeting. It's new population. First, I would say is older age. And it's very important because it's the real life of the patient we have to treat. And this morning in the late breaking abstract, one comment coming from the floor has been very interesting in this perspective, telling that in the CTN 703, I will talk a little bit about later, it's within 37 centers in the US, the median age of the clinical trial is 66. And a few years ago, it would have been a contraindication to transplantation. So we have really changed many things. And there was a workshop on Friday, 3 hours with workshop concerning aging and how we can approach this kind of question, how much on biology aspect, for example, the epigenetic could be of importance in this situation. So really, we are progressing in this field. And the second point is the advanced disease. We all of us know that we achieve better result when we treat a patient in CR1 with a negative MRD. But for the other one, there is no solution. So how can we approach the treatment of this patient? We are not really in the good group. And in this perspective, the first abstract I think that have been important is the one at the presidential session concerning the patient with relapsed or refractory AML after the first induction. It's a German study who decided to compare, prospectively assess the outcome after the standard approach, which is, okay, this patient is in failure. We will make a second induction with a standard anthracycline and hydroxycytarabine, compared to we will just wait in order to go as soon as possible to transplantation with a sequential approach. And it's this study, it's a non-inferiority study. And the main question that have been asked was the proportion of patients in CR 2 months after transplantation. And with only 281 patients, and remember, it's a non-inferiority study, they have been able to show that the two strategies are equivalent. And it is very important in this perspective. Median age of this patient was 61 in both arms. What is really important is to see that 80%, around 80% in both arms, achieve the endpoint. Once again, it's a CR on day 56, 2 months after transplantation at this time. And for the patient we are in CR at this time of post-transplantation, more than nearly 80% are alive in CR 1 year after this endpoint. So it is very, very important. What is important also is to see that when you don't do the transplantation right away and you wait to do the transplantation, they have been able to make the transplantation, to perform the transplantation 4 weeks after including the patient, which is something important, showing once again that we have made tremendous progress, notably in the possibility to find a donor. So it's, for me, it's something important. Second aspect in this program, and it has not been totally addressed, and we will see in the paper, because I do think it's important. It seems that there is less toxicity in terms of hospitalization of the patient. And this is something probably important because this toxicity, even if it's difficult to monitor it, is probably important in the long-term run, because this patient can benefit from, for example, from maintenance therapy after transplantation, which is important for this patient in initial failure. So this protocol has been something important, and there have been also a second randomized study which has been presented yesterday. It's the old, I would say, EBMT study that have been started. Well, that started 11 or 12 years ago, asking the question: is allogeneic transplantation as good or better than conventional therapy in older patients? Remember, once again, it's old study started in 2010, 2011. And the idea was to compare for CR1 AML, the outcome after FLUDA-TBI, because at this time, we didn't know how to to perform transplantation, notably in terms of conditioning regimen for these patients. And basically, the result show, and I will be short on this aspect because the results are very clear. Outcome after transplantation is much better than with conventional treatment. However, there are some caveats, some drawback in this study. It's an old study, once again, using FLUDA-TBI In fact, the 5 years overall survival is not, or leukemia-free survival is not this good, because it's 9% with conventional therapy. It's only 30% with allogeneic transplantation. And obviously, we will do the transplantation in another way at the present time. Nevertheless, results are what they are, showing that really allogeneic transplantation in this older population is important. The second information we get from this trial is clearly that not all patients can get transplantation. It's something we have to work on it, because basically, and you will see in other studies I will present, that basically 30 to 40% of the patients that we want to transplant never get the transplant. And it's something we are still to work on, because of course, there are the patients who need really this kind of approach. Another prospect, well, yes.
No, please. Sorry.
Another approach that I think will be presented is a French study presented by Régnier de Villiers on the behalf of the French group. It's a prospective study of different conditioning regimen. In fact, the question asked by this prospective study was to know if the increase in the intensity of the conditioning regimen, using the same conditioning regimen, but increasing the intensity, will give better results in older patients. And older patient in this protocol has been defined as patient above the age of 55. It's, as I say, a study that started some years ago. And all patients receive exactly the same conditioning. It's an association of fludarabine, busulfan, and ATG as GVHD prophylaxis prior to transplantation. And the only difference between the arms, there are 3 arms, is the dose of busulfan, 2 days, 3 days, or 4 days. And the background of this study was the fact that with fludarabine, 2 days of busulfan and ATG, we achieve good result, but not optimal result. And the question was, can we really improve this result? And there are two or three messages we can get from this study. The first one is the fact that we had to close the higher arm with 4 days of busulfan because of too much toxicity and too much side effect. And the toxicity associated with this increase in intensity is 4 to 5 times more than as compared to the BX2. So it's very important. Really, the dose intensity in older patients, we have really to be careful. And the second point is the fact that if we look to the result with only 2 days of busulfan, we have still good result, and survival is better. And there is not a real increase in disease relapse. So this kind of results, I think, are important because of the protocol and the clinical trial, but also because it's open field for the future. It means that really conditioning regimen and the initial part of the transplantation should be considered more and more as a platform to deliver further treatment for the patient. And to do that, we need, of course, to keep the patient alive, but also not to have too much toxicity in order to be able to deliver to this patient some additional treatment. So this kind of meaningful results are important for the future, and really we are building a new aspect on this in this field.
Thank you very much, Didier. This is really fantastic, and I'd like to announce that we just had the kickoff Argentina versus Croatia. So for those of you who are following, I'll be also updating you about the situation. You may be aware that Argentina are looking really to reach the World Cup final for the 6th time. This figure has been only bettered only by Germany, who were there for 8 times. They've never been eliminated, Argentina, at the semi-final stage before. On the other hand, please don't forget that Croatia were losing finalists in 2018. and they could become the fourth European nation to reach consecutive World Cup finals after Italy, Netherlands, and Germany. This is based on the information published on the BBC website. So I'll keep you updated, guys, about the soccer situation. Now, after 5 minutes, apparently the two teams are doing rather well. So when it comes to transplant, it looks like the field continue to evolve. We can find a donor for almost everybody. The population is becoming older and older, so we need to figure out how to handle the management of these elderly patients. But also, I think the technicalities of transplant are changing, especially now with the post-SI randomized trials, but also the possibility probably that we can proceed to transplant quickly without going through the burden of high-dose chemotherapy and its morbidities. Did I summarize it well, Didier?
Yes, very nicely. And I do. This is really illustrated by some aspect is illustrated by a nice study from the Memorial, showing that they analyze, in fact, prospectively their patient with CR1 AML, and they look for the reason why they didn't transplant some of these patients. It's basically 30 to 35%, as I said previously. And what is very important to see as a change in our practice, that in no situation, the reason was the lack of a donor, which is, and it's about 300 or 400 patients. So it's not nothing. It's showing that we have changed our practice. So it's very important. And if I have time, I will just give some words about some technical aspect, which is our GVHD and GVHD prophylaxis and treatment. And there has been this morning the prospective evaluation of two arms in GVHD prophylaxis. One was PTCY, tacrolimus, and MMF as compared to tacrolimus and methotrexate. Is a large number of patients who have been randomized, showing clearly that outcome it's only HLA matched transplant outcome is much better in terms of GRFS for the patient who have received the PTCY, which is something very important in this perspective. It's a US study, so the majority of patients with unrelated donor didn't receive ATG, but as we do in Europe, so it may change something, but at least it shows that we have new possibility. And I will just finish in the treatment that in the treatment of GVHD, and it's something that has been reported by you, Mohammed, concerning the use of microbial therapy, which is something so important in the situation of patients with GI GVHD. And what I have noticed in this early access of the microbial therapy in France is that the rate of response for patients who have been in failure of at least 2 lines of therapies, up to 6 lines, and nearly all patients have received ruxolitinib just before. The overall response rate is nearly 60%, which is for GI GVHD something very important, and patients are surviving long term after this approach. And I think that's a message of hope in this situation, which is very important. So many things, many other things I could have addressed. We have no time, but I'm sure that with the IACH, we will come back later on focusing on different aspects. But it has been a very, very interesting meeting.
Thank you very much, Didier, and thank you for highlighting our study about the use of microbiota in refractory acute GVHD. The ball possession between Argentina and Croatia is 58% for the Argentinian, 42% for the Croatian, and for the time being, it's going very smoothly. So no worry, Guy, I'll keep you updated. Let's move now to the myeloma field, and it is my great pleasure to welcome our three top experts, Dr. Marie-V Mateos, Dr. Jean-Luc Harousseau, and Dr. Salomon Manier. We're very glad, as usual, having you with us. And for myeloma, we need at least 3 experts because there are more 1,000+ abstracts at this meeting. So almost 1/4 of the total ASH 2022 meeting was dedicated to myeloma, which as usual is very impressive, but we know it has been the case since many years now. Myeloma driving a lot of innovations in hematology. So there are many keywords, I would say, in myeloma, and the first one was about, I think, bispecific. And here I'll take it by alphabetical order, and I'll ask Professor Harousseau on his take on the different bispecific studies that were presented at this ASH, and the value and the teaching in the we can glean from what was presented.
Thank you, Mohammed. Thank you for inviting me. And I will start by 2 general considerations. First, you are very clever and you know everything about football, soccer, which is for me a great surprise. Second, I think that for the clinician, this 2022 ASH meeting did not offer major breakthroughs. We had a few small number of results of randomized clinical trial because large clinical trials are either ongoing or not yet mature. But I think that we had a number of very important confirmation or informations, especially in the field of immunotherapy. So to answer your question regarding bispecific antibodies, we had some very important presentation. Maybe and I think that the other expert, Marie-V and Salomon, will certainly be could add their own opinion, but in my opinion, the most important was probably the talquetamab TAL1 study, which was presented by Shari. And this is an important study because the target is not the same as the previous BCMA targeting bispecific antibodies. We already knew about talquetamab, but it was an update, and it was a very important update on a large number of patients. There were 2 different dosage and schedule of administration, and 143 patients per arm. And the take-home message is that in a heavily pretreated population, as usual, the overall response rate was 63%. And in a previous patient, in patient who had previously received T-cell directed BCMA immunotherapy, there was also a good response rate of 44%. There were other important presentation regarding elranatamab, for which we already had the information, but it was actually 2 presentations, one by Nopur Raji and the other by Balis. The most important one is a magnetism-3, because it's a larger number of patients, and it's also important result in heavily pretreated and high-risk population with 30% of extramedullary disease and almost 100% of triple class refractory. So the response rate was very important. Of course, less important than for CAR T cell, but in the range of the other bispecific antibodies, 61% and 27% CR or more. The important point with this antibody, like with the teclistamab, is good feasibility and the good safety profile with very rare grade 3 CRS syndrome. So it's another BCMA targeting specific antibody. So there were other, but I will let the other expert discussing the other which were presented. There was especially a presentation by Susan Trudel regarding cevostamab, and in my opinion, this bispecific antibody targeting FCRFC, is, in my opinion, less active than the BCMA and then the talquetamab. But maybe the other expert could give their opinion on all these bispecific antibodies. So really, the field is moving. We already have a presentation regarding combination of teclistamab plus daratumumab, combination of elranatamab plus daratumumab. So the field is moving very rapidly, in particular to look at the way the BCMA targeting immunotherapy could be sequenced, which is an open question.
Excellent. Thank you very much, Jean-Luc. By the way, it looks like Croatia just taking the sting out of the semifinal by knocking the ball around with huge confidence. Argentina is trying to get Messi into the game, but Croatia side have been around the block. So very exciting.
You should change your job. You should be a TV,
who knows?
Journalist for football.
Sport analyst.
But it is very exciting. And just to highlight, Jean-Luc, you were referring actually to the talquetamab paper, which was released actually during this ASH in the New England Journal of Medicine, and the first author was our colleague Ajay Shari. Marie-V, do you share the same enthusiasm? Any other thoughts about this bispecific story? But also, I've seen that the Spanish different institutions and groups have spoke a lot about MRD, mass spec, and it looks like this message of minimal residual disease is now quite consistent across all malignancies in hematology. So what are your thoughts?
Yeah, so first of all, thanks for the invitation. Second point, I agree with Jean-Luc. I think that, well, the BCMA landscape with bispecific monoclonal antibodies is moving forward. And during this ASH meeting, we had the opportunity to see consolidated results coming from many clinical trials. He alluded to talquetamab targeting GPRC5D. Just to mention that Roche presented also another GPRC5D bispecific monoclonal antibody, also with exciting results. And for me, the most important information is in these clinical trials, targeting GPRC5D patients previously exposed to BCMA targeted therapy were allowed to be included. So I think that with a longer follow-up, we are going to have much more data in order to plan an appropriate sequencing of therapy, what from my point of view is something very relevant right now and especially in the near future. And alluding to your comment about the role of a measurable residual disease, it's true that we know today that it is one of the most important prognostic factors in myeloma. You said in other hematological diseases as well. And in myeloma, you know how in all clinical trials we incorporate measurable residual disease. And in some clinical studies, indeed, sustained minimal residual disease negative over time. And this is something in which the Spanish myeloma group is working. I had the opportunity to report the results of a sustained MRD negativity rate in a trial conducted by the Spanish myeloma group in high-risk smoldering myeloma patients. And we had the opportunity to see how approximately 45% of the patients sustained the MRD as negative 4 years after autologous stem cell transplantation. And also, when we have analyzed this data, we realized that to go to the bone marrow even once per year sometimes is not the optimal way in order to evaluate the measurable residual disease. Point number one, because between today and 1 year later, many things can happen and some patients biochemically progress and we are not able to capture the positivization of the MRD during this year. And point number two, because we have to go to the bone marrow, some patients don't want to go to the bone marrow. Some physicians forget to do the bone marrow, and this opens the door to evaluate definitely the peripheral blood as the ideal place in order to evaluate the measurable residual disease. And some presentations have been done coming from the Spanish myeloma group with measurable residual disease in peripheral blood by next generation flow and also by mass spectrometry. I think that the work is in progress for both technology. Well, yesterday there were 2 presentations based on this, the evaluation of the measurable residual disease in the peripheral blood is feasible. It's true that we have to collect approximately 50 milliliters of peripheral blood in order to concentrate the tumor cell and in order to be able to evaluate the measurable residual disease with a high sensitivity level. But the prognostic value has been confirmed in a clinical trial conducted by the Spanish myeloma group in newly diagnosed myeloma patients. And the same approach for mass spectrometry. I think that mass spectrometry is easier from the technical point of view because you need just to collect a tube of peripheral blood, and in the serum you are able to detect the molecular mass of the M component of each specific patient, so you can track this molecular mass of the patient, and there is a good correlation with next generation flow in bone marrow. Maybe the next comparison will be to evaluate bone marrow and peripheral blood by next generation flow and mass spectrometry. Definitely mass spectrometry distinguishes the 2 different subgroups of patients with different prognosis. It's true that today the prognostic value is a bit lower in comparison with next generation flow in bone marrow, but can complement and can guide the optimal timing for going to the bone marrow, because if you do first mass spectrometry and you detect the M component, definitely it is not necessary to go to the bone marrow. And on the other side, it is easy to track the peripheral blood and mass spectrometry in the follow-up, and maybe the reappearance of the molecular mass of the M component can guide early rescue interventions.
No, this is really great, Marie-V. Thank you for emphasizing this. And I would like to emphasize that from a patient perspective, this would be a huge advance to be able to track the disease without the need to do a bone marrow aspirate. Currently, the majority of the action between Argentina and Croatia is taking place in the middle of the park. Not much in the way of opportunities, but it looks like that the Croatian are a bit dominating, 61% of the ball possession. Salomon, any thoughts on this? But also we would like to speak about the CAR T cells and the different cellular therapies. But maybe I would like also to incorporate something new we heard at this meeting, which is about the innate immunity engagers, because we spoke a lot about the bispecific and T-cell engagers, adaptive immunity, but now immune-mediated immune immunity is now on the podium. What are your thoughts, Salomon?
Yeah, so I mean, I totally agree with Marivi, and I think she summarized the things very, very well. And we probably need in the future to have those liquid biopsy emergency evaluation for the patients, and that will definitely help their quality of life, and will be able to hopefully to have treatment decision based on that. So it's clearly a very good news to see those different studies evaluating different approaches for MRD in blood biopsy. So regarding the CAR T cell, yeah, we had some data of CAR T cell, and we had an interesting report, I think, of a old CAR T cell that we knew. It's called Orva-cel. It's a human BCMA targeting CAR T cell that we had some reports before, but here they used a different mechanism of manufacturing. It's called the NextT process, and it's a very short time manufacturing process. So within 1 day, 2 days, the CAR T cells are manufactured, and of course you need to wait for the QC control, but then you can reinfuse the patient. So has two different advantage. One, of course, is to try to shorten the bridging period and this manufacturing time, but also, and perhaps more importantly, we know that after leukapheresis, when we do this manufacturing, we have, of course, to grow the cells ex vivo, and we have to stimulate the cells with IL-2, and this can induce some kind of exhaustion of the T cells. So there is an interest to do this very rapid manufacturing to try to avoid indeed the T cell exhaustion. And it's actually what they show. They use this construct of Orva-cel with this new manufacturing, and they compare to the old fashioned manufacturing, and we can see that there is an increase of the memory T cells, the naive and the memory T cells that will drive the response. They have very interesting response rates. So this is, I think, an important proof of concept that short time manufacturing is something very interesting for CAR T cells, and probably should be considered for the future development of CAR T cell in myeloma, but I'm sure it's true in other diseases. So regarding the immunology field, and I think something was also interesting. It's still linked to the bispecific antibodies, but we had two interesting, among others, of course, two interesting reports of correlative studies on bispecific antibodies. So one was a correlative study on Majestic-1 with the teclistamab, the BCMA CD3 bispecific antibody. And so they looked at the marker of response and resistance of those patients. And basically, there are some markers that are linked to the disease. So some are, expected, but it's, I think, always good to know the things and to demonstrate the things. So patients with high soluble BCMA, high tumor burden, had lower response rates. And our IACH as well were showing up as a factor of adverse outcome and poor response to those bispecific antibodies. It's interesting, actually, the story of ISS, because it's IACH is showing up as a factor of adverse events in all immunotherapies in multiple myeloma, CAR T cell bispecific, and it's probably linked to beta-2 microglobulin, which is part of the HLA class 1 receptor. So it probably does induce some kind of immunosuppression of the microenvironment of the patients and decrease the response of those new generation immunotherapies. So high tumor burden and IACH, and also they were able to look at the T cell compartment of those patients, and they demonstrate that patients with high rates of CD8 exhausted T cells have shorter PFS, and patients with a high rate of Tregs, T cell regulator lymphocytes. So this is interesting. We will need probably in the future to have some kind of tools with thresholds where we can assess those exhausted T cells, those Tregs in the patients in a clinically routine manner, so that we can use this information to treat our patient. But I think it's an important piece of data. It's the first correlative studies that we have for bispecific, so that was good to see. And the second one is from the team of Nizar Balis and Paula Neri, and they looked at the mutations of the antigen BCMA or GPRC5D of patients who were treated with bispecific antibodies, and for some with CAR T cells. And so what they observe is that, so they look at the antigen escape, basically. And it was known that some of the patients can lose BCMA by biallelic deletion of BCMA. This has been reported, and they find again, 1 or 2 patients with the same situation. But on the top of that, and this is a new information, they find some patients with point mutations of the BCMA receptor, and they do functional analysis to demonstrate that actually the mutation happens at the binding domain of the bispecific antibody and impair the efficacy of the bispecific antibody. So it's a new mechanism of resistance to bispecific antibodies, so that was interesting. And it's the same observation for GPRC5D. They reported for the first time a biallelic deletion of GPRC5D in 12p, so it can also happen. It doesn't seem to be very frequent as for BCMA, but it can happen. And they demonstrate as well a case of mutation in the GPRC5D binding.
Salomon, the game,
Sure.
big moment. There is a penalty for Argentina because we had 30 minutes of a very well-balanced teams, but there is a penalty now. Okay, now.
It's what I wanted to say, Mohammed, so I leave the floor to you.
Okay, wonderful. Thank you, Salomon. Maybe
the p-values. I was just going to say the p-value for penalties for Argentina in this Mondial is like 0.001.
So that means they have a very good hazard ratio and likelihood of getting 1 point now.
Yep. Yes.
Well, this is confirmed actually, guys. Primary endpoint achieved for Argentina. They are now 1-0. So we will keep you updated. We will keep you updated between Argentina and Croatia, 1-0. Marie V, would you like, I think, and Jean-Luc to comment on, we've been praising nicely, and I think they deserve it, the bispecific antibodies. But maybe I would like to have a couple of words with you about the issue of infections and severe hypoglobulinemia. I crossed by, for instance, during IACH, a study by Dr. Lankman showing that the incidence of severe infections can go up to 40–50% over time, up to 1 year after receiving bispecific. Any comments on this?
Yeah, sure. I think that this is one of the major issues when we treat the patients with bispecific monoclonal antibodies. And I would say that the problem will be, from my point of view, more and more relevant as soon as these T-cell engagers move to earlier lines of therapy. But I think that we are at the appropriate time in order to try to prevent or in order to take into consideration this problem. Why the incidence of infections is higher than expected with these BCMA CD3 monoclonal antibodies? I think that there are multiple factors, but we have to consider that the BCMA has a physiological function involved in the production of normal immunoglobulins. So if we attack continuously as continuous therapy BCMA, the final result is severe hypogammaglobulinemia over time. This can potentially contribute to infections, together with the fact that these BCMA CD3 monoclonal antibodies engage T lymphocytes into the tumor niche. So at the end, we see how there is going to occur a T cell depletion after the bispecific monoclonal antibodies that can also potentially contribute to some infections or some viral reactivations. In addition, well, when the T lymphocytes are activated and they contribute to kill and to destroy plasma cells, well, other cells and neutrophils can also be destroyed. Cytokine release syndrome and so on can contribute also to neutropenia that we usually see during the first priming doses and the first cycle. If we added myeloma as an immunosuppressive disease, patients treated after 6-7 prior lines of therapy, I think that the final conclusion is we see these infections. But what it is different from my point of view, in comparison with what we've seen until now in myeloma concerning infections, is that these infections occur over time and they are not concentrated at the beginning of the treatment. This means that we have to try to prevent these infections with adequate prophylaxis. And point number 2, maybe we have to optimize the durability of the treatment with bispecific monoclonal antibodies, especially when they target the BCMA. And maybe these 2 measures will contribute to reduce the number of infections we are observing right now. And BCMA is a main target in order to result in infections. When we analyze or when we evaluate the infection rate with GPRC5D-CD3, the infections do exist, but the incidence is lower.
Excellent. Thank you very much, Marie-V. Always very nice analysis. And here, maybe Jean-Luc, you can comment, because we're talking about infections, we're talking about morbidities, we spoke about quality of life, and maybe if you can say a word about what Salomon presented on behalf of the IFM, the analysis where they were able to get rid in the group, getting rid of dexamethasone, and how important it is, because in my opinion, it's something which can be practice changing, the issue of being free of dexamethasone at some point. We need your microphone, Jean-Luc.
I was saying that I'm a little embarrassed because it's a French study, but I think that it is really an important study. From years, we have shown that dexamethasone is very useful, and actually dexamethasone is used at all stages of the disease, frontline and 6 or 7 line of therapy. We know the side effects and the morbidity and even mortality related to dexamethasone, even low dose, since we have adopted the way of prescribing dexamethasone after the IACH trial. So the objective of this study was to try to treat elderly, frail patients without dexamethasone, except the first 2 courses where it's necessary to be rapidly active. And this is a randomized trial between the usual lenalidomide dexamethasone continuously and DARA sub-Q plus lenalidomide, but without steroids, without dexamethasone. Salomon did present the preliminary data, which are very encouraging. The primary objective will be progression-free survival, but the study is not mature yet to present this data, but he presented the result at 1 year, showing first no difference in terms of infections, despite the hematological toxicity of the DARA sub-Q Revlimid arm, which is slightly higher than the Lendex classical treatment. But second important message for me, and this was a little bit expected, is that the response rate is superior with DARA plus Revlimid compared to the standard arm. So of course we will need the updated analysis, but I think it's very encouraging, and that for frail elderly patient, knowing that for fit elderly patient, the standard of care is currently DARA Rev-Dex, but for frail patient where a triplet could be more dangerous, especially with Dex, we are expecting very good efficacy with DARA subQ plus Revlimid without dexamethasone.
Excellent, thank you very much. And it's all coming up for Argentina, 2-0, guys, for Argentina. So we're currently at 39 minutes of the game, and the first penalty was at 34 minutes by Messi. At 39 minutes, it was Alvarez. He was like a magician. Okay, so Salomon, up to you again. I asked you, but you didn't comment on the innate immunity engagers, which were very exciting to me.
Yeah, so we have some preliminary data on this innate immunotherapies. So the concept is that instead of using the T cells, we can use innate immunity and NK cells to generate, for example, CAR NK cells. So that's something very interesting. It can be also off the shelf because NK cells don't have the HLA system, so you don't have the problem of GVHD, or so it can be off the shelf basically. So this is very exciting, and we start to have some data which are still a little bit preliminary on this kind of approach. And yes, it's very interesting. It could be either on itself, it could be combined in the future with probably other treatments, but it's something that will probably be taking more and more space in the landscape of treatments in the future in multiple myeloma.
Wonderful, thank you very much. We are reaching almost the end of this broadcast. I think all the panelists did a great job. So in the last 2 or 3 minutes, I would kindly ask all those who are still in the broadcast, because we had Professor Zedan, Professor Bazarbashi, who needed to leave to catch up their plane, to say one word, one sentence about this ASH 2022 for them in their field, but also what they're feeling for the future. And maybe I can start with you, Mohammed, because you want to leave also to catch up your plane.
Yeah, thank you very much. This is an amazing program, and I really enjoy participating and learning from all of the experts in this program. I think that if I were to summarize in the field of lymphoid malignancy, the future continues to look very bright. I think what we would like really is to increase access to all of these therapies to the rest of the world. I don't think we will do a service to mankind if we just limit countries and not offer them to the poor countries. So something has to change to make this more accessible, but certainly we are living through revolutionary times in the history of treatment of lymphoid malignancies, and certainly other treatments as well. And thank you again.
Thank you, Mohammed. This is a very important message about availability, accessibility, and affordability of innovations to all patients across the globe, because of course, all patients deserve the best. Didier, what's your take-home message?
I would say that we are really in a very moving situation. The world is changing, and our world, professional world, is changing. But this time, I would say in the good way, because we are progressing and we have the possibility now to offer many more treatment to our patient with very good chance of cure. So it's very important and very exciting.
Excellent. Salomon?
Yeah, we clearly are seeing a revolution in the treatment of multiple myeloma. If we go back 5 years ago, for example, it was a different landscape completely. So it's very rapidly changing, and probably that this ASH was kind of the end of the first, I would say, cycle of the development of these immunotherapies. And we have now a lot of information on patients who are at relapse, late relapse, early relapse. We start to have some data, and I think we will be entering a new kind of cycle of development of these immunotherapies starting 2023 with the frontline use of these immunotherapies and probably like the large use of them. And hopefully we'll be able to have a large access of these immunotherapies everywhere.
Thank you very much, Salomon. Very nice comment. Of course, we are at the break now for Argentina and Croatia. So I have no news to update you. Marie-V, your take-home message.
Well, I think that in myeloma, our dream is to cure. And I think that the work is in progress. We are having, I would say, the key elements in order to achieve the cure: risk and response adapted therapy. And we have plenty of novel combinations or novel drugs that will contribute to achieve this goal.
Well, this is a very great message of hope. Cure, I love this word. And last but not least, I have on purpose and deliberately left the last word
as
to
usual,
you, Professor Haruso, because, well, you are the voice of wisdom, and you have this like 35 or 40 years of observing the field. You've been initially involved in AML, in myeloma, in transplant. So how do you have this like overview from above looking, and now you're retired, so you are enjoying the science?
Okay, so usually I give only one take-home message, and then to finish, I would like briefly to give 3 take-home messages. First, continuing what Marie-V said, looking at the way to cure patients, I think it's important to focus on one possibility, which is to treat patients earlier. She did, of course, present the James Caesar Spanish trial, but Shaji Kumar also presented the preliminary results of the ASCENT trial, which has also the objective of curing some patients without transplant, but with a very aggressive treatment for a limited period of time, and the preliminary results are very interesting in terms of MRD achievement, for instance. The second message is that we still have unmet medical need. The most important unmet medical need is triple class refractory. We currently have solutions with CAR T cells and bispecific antibodies, but we have the question of what to do after these drugs. And there is just 2 drugs that I would like to mention, which could be useful in the situation of triple class refractory or even after BCMA targeting agent. We have mezigdomide, which is a new cerebral modulator, which provides interesting results, especially in triple class refractory and in patients who have already been treated with an anti-BCMA agent. And we have also a very special immunocytokine called modakafusp alpha, which is an anti-CD38 antibody with attenuated alpha interferon genetically attached to the FC portion of the antibody. And again, this provides interesting preliminary results in patient refractory to daratumumab or triple class refractory patient. And my final point is another important problem for us, which is the treatment of high-risk multiple myeloma. The first question is how to define this high risk. And there were several presentations focusing on the need to individualize patients at a higher risk that they call ultra high risk. For instance, Martin Kaiser focused on the double hit cytogenetic abnormality. So we are working on the definition of ultra high risk, but we already have clinical trials showing very encouraging results in this group of patients. For instance, we had the presentation on the German GMG concept trial by the combination of quadruplet with isatuximab KRD, and these results are very encouraging in high risk, very high risk patients. Of course, the number of patients is still limited, but the percentage of MRD negativity at the end of induction consolidation with isatuximab KRD is very encouraging at 68% in transplant eligible patients. And we also had the results of the so-called Optimum trial from the UK presented by Martin Kaiser, again with a very aggressive strategy of quadruplet and even quintuplet combination with DARA, cyclophosphamide, VRD, induction plus consolidation plus maintenance. And in both trials, maintenance was a combined maintenance with 2 or 3 drugs. And again, the results are very encouraging in terms of progression-free survival at 3 months, 69% in patient defined as ultra high risk. So it's another hope for the future with the drugs we have, and by combining all these drugs and by using long-term combined maintenance treatment, we could improve the prognosis of this patient with ultra high risk multiple myeloma. So many avenues, new avenues for either looking for cure or at least improving the outcome of the patient with the most, the highest risk multiple myeloma.
Well, thank you so much, Professor Haruso, for the wonderful key take-home messages. Thank you all for joining us for this live broadcast from New Orleans. It's almost 2 p.m. here in New Orleans, almost noon in San Francisco, 9 p.m. in Paris, 8 p.m. in London. You all did really great. I'm very grateful to all of you. And clearly, after 3 years of pandemic, this in-person ASH 2022 meeting in New Orleans has definitely boosted our energy, increased our optimism and enthusiasm. It has confirmed the ongoing revolution in hematology, and at least on a personal level, it has strengthened my belief in a better outcome and cure for many blood cancers. So I would like to thank all the investigators, all the researchers, all the students, the fellows, the physicians, the nurses, the healthcare professionals, all the stakeholders who are involved in all this for their efforts, for their dedication. I'd like to thank the audience for following us. I'd like to thank the ASH organizing committee for allowing us to enjoy a fantastic meeting in a lovely environment and with great safety measures. So wherever you are, if you are flying, if you are about to fly, I wish you safe travels. I wish you also some nice end of the year holidays. Wishing you Merry Christmas, Happy New Year, and in the meantime, please stay safe and keep well. See you soon.